Good morning, everybody. Thank you for the committee for such opportunity. Today, our presentation about the long-term outcomes of dedicated venous stent in management of chronic iliofemoral obstruction. Our objective in this study is to study the outcome, a long-term outcome in patients with occlusive iliofemoral chronic venous insufficiency of benign etiology treated by dedicated venous stent at single center. Our methodology is to perform retrospective analysis of prospectively collected data from 58 patients with symptomatic benign low limb CVI, started from January 2013 to October 2020. After fulfillment of inclusion criteria and exclusion criteria, the patient was enrolled and clinically classified according to C classification. But throughout our study, we used the venous disability score and 𝗦𝘆𝗺𝗃 scale throughout at the time of treatment and over the follow-up period, which was at 1, 3, 6, and 12 months, and average for 5 years. After radiological assessment through duplex ultrasound examination at each follow-up visit, technique, we would like to highlight that the type of stent was 𝗔𝗹 venous stent, which was the first dedicated venous stent in Egypt at that time. Unfortunately, the IVUS was not available at our institute in this time, followed by pre-dilatation, increasing diameter, non-compliant balloon, followed by primary stenting in all patients. Post-operatively, the patient received clopidogrel, new oral anticoagulant, and early stocking in every follow-up period. Our results was stenting of all patients, 58 patients, all were positive thrombotic. The majority of the C classification, baseline classification, was C5 and C6. The main, on the majority of cases, the initial venous access was popliteal vein. Based on CT venography, the 51% of patients has a common and external iliac vein involvement with mean total length of treated segment about 15 centimeters. As regards the stenting, the majority of patients, about 51%, underwent stenting of common iliac, external iliac with extension of common femoral vein, only in 39% of patients. With availability of longer stent in 𝗔𝗹 vena, the maximum number of stents was 2, with overlap about 2 centimeters between the two stents. After a 5-year follow-up, the 95% of patients completed this 5-year follow-up with primary patency about 60%, assisted primary about 65%, and secondary patency 81%. With marked improvement in 𝗦𝘆𝗺𝗃 disability score and good improvement through 𝗦𝘆𝗺𝗃 scale. When we are reviewing the evidence, the 12-month patency rate in our study was comparable to that of published by 𝗘𝗴𝘆 et al. And higher than that published by 𝗦𝘆𝗺𝗃𝗀 et al. Unfortunately, the studies describing long-term patency for dedicated venous stents are scarce. In our study, 5-year patency rate, assessed primary, secondary patency rate about 60%, 65%, 81% respectively, which was slightly less than composite wall stent, Z stent approach, and comparable to that of different type of venous stent, which none of them were dedicated, reported by Mahboud et al. This study also was comparable to Neglen et al.'s results using only wall stent and that of Gagné et al. This result showed non-inferiority of patency as a dedicated venous stent, plus there is non-encroaching contralateral CIV as advantage, and literature currently recommend recognition of long lesions using long stent to minimize the complication. Conclusion: treatment of occlusive iliofemoral venous disease has become a cornerstone for treatment of PTS. Recognition of using dedicated venous stent is an excellent choice and non-inferior to wall stent with respect to 1 and 5-year patency with good clinical improvement. And available long stent decrease the overlapping length and overlapping of a number of stents with decreased the fractures and encroaching through over the contralateral CIV, decreasing the probability of complications of the contralateral limb. Thank you.
Thank you, Dr. Hamdy. I have a question for you, please.
Okay.
You have depended on only venography for evaluation of these patients' clinical scenarios?
Throughout the assessment period, I passed the slide firstly because of short of time. We use clinical examination of this patient using either C classification or venous disability and Velta scale, then followed up by duplex examination for all patients. In the stage of venography, in the case of patient will be underwent preoperatively.
My question is, does duplex influence your decision whether you stent these patients or not?
No, I don't think so. The duplex, it was a standard for all patients.
You would think that a patient with a multi-level 𝗓𝗏𝗡𝗆𝗆 infrapopliteal venous reflux,
yes, it will influence my results.
Would benefit from iliac venous stenting if you don't. If you just look at the iliac segment.
No, we make sure that there is no infrainguinal disease segment to ensure at least a deep femoral vein or femoral vein patency as in flu, and the proximal outflow patency to the stent later on.
And do you see a lot of patients who have only isolated iliac segment?
At least our 58 patients. I found them
with either isolated
yes,
iliac lesions with no femoral-popliteal lesions?
Yes.
I find this quite rare. Thank you.